Very good morning to everybody. And we see that quite a number of people have gathered, and we expect more people to gather as the morning progresses. Uh, we have with us, we have the honor of Dr. Ajit Bhide addressing this session for us, and it's interestingly titled uh, Roots and Shoots. Uh, the theme is, of course, severe mental disorders. About the facilitator today, Dr. Ajit Bhide is a psychiatrist and a psychotherapist and past president of the Indian Psychiatric Society. He is an alumnus of Joseph's Boys High School, St. John's Medical College, and NIMHANS, where he did MD in Psychology Medicine in 1982. Dr. Bhide has served on the faculty of the latter two institutions, and at college, he was a debater and best actor at the All India Mardi Gras in 1977. He joined Martha's Hospital, Bangalore in 1987 as a consultant psychiatrist and headed the department there from Jan 1996 to Jan 2021, and is now Emeritus Consultant there. He introduced the family medicine PG residency program in the hospital in 1996. His areas of interest are child and more particularly youth mental health, family issues in psychiatry, anxiety disorders, personality disorders, psychotherapy, media and mental health, evolutionary biology, and preventive and social medicine, especially preventive psychiatry. He has presented about 2 score lectures, workshops in CME programs across the country. He is currently associated with NGOs working in the field of mental health, mainly the Medico-Pastoral Association, which pioneered rehabilitation work in India. During his term as the national president of the IPS, that is the Indian Psychiatric Society, and the tenure was 2018-19, to which he was elected unopposed. He was instrumental in having homosexuality decriminalized. Also, in his term, the Medical Council of India adopted ethical norms for all doctors that his task force had framed for psychiatrists regarding boundary violations. Psychiatric Society at the national level, he has been serving it at the national and state levels in Karnataka. He has also acted in 3 movies, including Stumble, which won the National Award for the Best Feature Film in English in 2002. He has also dabbled in modeling. He lives in Bangalore with his wife, who is a school teacher. Their daughter is a microbiologist and a management consultant. Incidentally, I had the honor of Dr. Ajit Bhide hosting me on one of the Golden Jubilee lecture series of the Medical Pastoral Association, I think 1.5 years ago. And that's where our friendship developed into a closer bond. Over to you, Doctor. And once again, an honor and privilege to have you addressing us. A person with such a multifaceted background, not only in the medical field, but his pursuits in the arts.
Thank you, Vijay, for that very kind introduction. It helps also when you write your own introduction to some extent, and then you have somebody else garnish it, as Vijay has very neatly done. I'd like to start my presentation with a word of apology. There are some things we will not be covering today, though the main theme is severe mental illness. I will not be looking at certain severe mental illnesses, for example, related to substance abuse, related to personality disorders. The two are interlinked as we know. I will be concentrating mainly on the scope of the schizophrenias and the bipolar disorders. I'll start with my PowerPoint presentation now.
Yeah. Sure. Yes.
So my presentation is titled Roots and Shoots. And by
So
this,
could you go on to full screen mode?
Is
So
it
that
not
would
visible?
So, I mean, you can go to the full screen from the PPT itself. Yeah. So
I
it will
thought
be
it's full
more
screen right
visible.
now. It's not.
No, no, it isn't. We are seeing your template, entire template.
Okay, just a
Of
minute.
course, this is also workable, but I think that
Wait
would
one
help.
second. 1 second.
Sure.
I'm not, I must apologize because I'm not particularly tech savvy. I especially miss my daughter who used to guide me in these things, who is
Okay.
not around at
So,
present.
okay, somebody has prompted you, pressing F11 will do it. So we have got techies within our community as well,
Terrific.
doctor. Yeah.
So my presentation is titled Roots and Shoots, and we're looking at the origins and the consequences of severe mental illness. And among the consequences, we will include what can be done. I must say that while we will be mentioning medication, for instance, we are not mentioning any specific medication for any specific condition for that matter, but we will be harping on the importance of medication when we come to the consequences of severe mental illness. Next. Now, the National Institute of Mental Health a few years ago, and this is the best definition we could have, defined severe mental illness as a mental, behavioral, and or emotional disorder resulting in serious functional impairment which substantially interferes with or limits one or more major life activity. It is an umbrella term for chronic psychiatric disorders such as schizophrenia and schizoaffective, delusional, major depressive, and bipolar disorders. We will be concentrating largely when we speak of SMIs on the schizophrenias and bipolar disorders. Next. Now, going to the roots first, I entered psychiatry at a time when the schizophrenogenic mother, such a fashionable term at that time, was just leaving. We will have more to say about the schizophrenic mother, a hypothesis of what brought about schizophrenia by parenting, especially by the mother. It was a fanciful explanation based on somebody's experience as well as bias. So schizophrenic mother was leaving, and the dopamine hypothesis was gaining ground in understanding the causation of schizophrenia. This understanding of a particular neurotransmitter being responsible for bringing about this rather awful malady was gaining momentum at that time. And we had a lot of evidence that has not been refuted. It is becoming more and more robust. But we also know now that dopamine alone is not responsible, but more about these chemicals a little later. Next. Now, I want to emphasize this. Every illness is to be understood as an aberration of the physics and chemistry of the body. Whether you have tuberculosis or whether you have multiple sclerosis or whether you have an influenza infection, it is always the physics and chemistry of the body that gets compromised. In our case, the physics and chemistry of the nervous system, specifically the brain. We have to first acknowledge this. Next. Now, we are talking about the biological basis of the severe mental illnesses. When we're speaking about the biology of severe mental illnesses, does that preclude the role of other factors? It clearly does not. Adversities and stresses do bring about different degrees of breakdown, but these are, we must remember, effected through alterations in the physiology of the brain. And we mentioned dopamine a little while ago. This is mainly through the alterations in the chemistry of the brain, or how the chemicals in the brain at that particular juncture are functioning. In the case of severe mental illnesses, it is a kind of chronic process where the chemicals have got deranged to a considerable degree for a very long time. That is the unfortunate thing. Next. Now, Dr. Vimla and I were talking in the beginning, and we were speaking about a spectrum, and we were speaking about a continuum. How are the two related and how are the two different? The commonalities are very many. Different things can take, different phenomena can take different forms, and that is what we talk about when we talk about a spectrum. We know Newton's great experiment to split up regular sunlight, or as it happens, white light, into the 7 colors of the spectrum. The Vibgyor spectrum is very well known. On the other hand, once the spectrum is split up, you cannot rejoin them easily. Nobody has tried to take those 7 colors of the spectrum and put them back into white light, as far as I know. But if there are physics and light specialists over here, they're open to correcting me. A continuum, on the other hand, is when one thing, can we stick to the other one?
Yeah.
We can
So,
see somebody over here. I mean, this is a slightly light-hearted one. There's a smiling face, then there's a neutral face, a slightly low face, and then a weepy, sad face. We know that we go through this continuum in our day-to-day lives. Some people are more prone to certain emotions, some people are not. And there is a commonality between spectrum and continuum in that they both relate to one phenomenon, which can be split up or which can change over a period of time. Now, we know when we speak about schizophrenia, for instance, we have something called the positive syndrome of schizophrenia. We have the negative syndrome of schizophrenia. A positive syndrome can continue onto a negative syndrome, which is a very common phenomenon. But very rarely will you see a negative symptom going on to altering into a positive symptom. That can very rarely actually happen. If we look, next slide.
Yeah.
Before that, we have a mental health continuum, for instance. Here you have positive and a healthy state going on to a less able state where it is difficult to deal with stresses. Then we go on to suffering from severe mental illnesses. Can this be altered? Can this continuum come backwards? That is what we are aiming to do much of the time, but unfortunately, rarely adequately succeeding. Next slide, please. I've mentioned that we are dealing mainly with the schizophrenias. Now, schizophrenia was thought to be a unitary illness taking different forms. It was sort of a spectrum. So you had, in the classical teaching, you had catatonic schizophrenia, you had paranoid schizophrenia, you had simple schizophrenia. This kind of classification no longer is acceptable. So we think about them as separate illnesses, which may have some linkage with each other. So we call them the schizophrenias rather than a single schizophrenia. This acceptance of schizophrenias rather than schizophrenia as a single entity happened a few years ago when we observed the centenary of the coining of the term schizophrenia by the great psychiatrist Eugene Bloiler. Now, do people with schizophrenia give rise to offspring who are likely to have schizophrenia and not bipolar disorders? On the other hand, with bipolar disorders, do we have children who are prone only to bipolar disorders? In other words, do they breed through, or is it a continuum? For a long, long time, when Emil Kraepelin, the great psychiatrist, differentiated between these two, of course, he didn't use the word schizophrenia, he called it dementia precoce. Please forgive my knowledge of his mother tongue, but that's how I pronounce it. He thought they were two very distinct illnesses, and indeed, to a great extent, they are. But we notice now that there can be a great degree of overlap between the two. One can transit to the other, and we should be aware of this. Most commonly, they breed through, but sometimes it is a continuum. So we have both a breeding through phenomenon as well as a continuum. Next. Coming specifically to the causes of schizophrenia, we know that genetics plays a huge role. Mental illnesses often run in families. A person with a close relative who has an SMI has a greater risk. More about this in a little more detail, just a little while from now. Now, the brain chemistry and the brain structure also gets altered. There are imbalances in the so-called neurotransmitters. When I was a postgraduate student 30 years ago, it was still called putative neurotransmitters, but because the phenomenon of neurotransmission had not clearly been understood and robustly established. But now we know they are actual neurotransmitters. And the principal neurotransmitters in the context of SMI are dopamine, serotonin, and glutamate. These are linked particularly to schizophrenia and to depression. We also know that there are structural brain abnormalities, especially in certain parts of the brain, the frontal and temporal lobes. I should also mention the hypothalamus and the amygdala, which are a little lower in the brain, but not lower in priority. But these lobes we are very familiar with. These have been observed both in schizophrenia and bipolar disorder. Can we definitely establish that these are the seats of the illnesses? Yes, we can. But do they tell us enough about what brings about the change? Not yet. We also know that around the time of birth and just after the birth, there are certain complications that can occur. Exposure to certain toxins and infections, particularly German measles called rubella and influenza. these two infections can greatly affect the development of the brain, the chemistry of the brain. Also, we have the phenomenon of malnutrition, and not to make light of it, we are seeing a phenomenon of rampant, rabid malnutrition going on in a little to our west. In the wars that are going on, we see horrible malnutrition that is occurring over here. I'm not here to make any political statement, but my conjecture is that we are going to see a lot of severe mental illness as a result of the severe malnutrition that young people are being subjected to, even babies. Complications during the birth can also increase the risk. For example, there is a finding that the forceps deliveries are much more represented in people who have severe mental illness in the long run rather than in the general population. Now, there is also another birth-related phenomenon. Births at a certain time of the year perhaps predispose individuals to certain complications, among them SMI. Then again, an elderly father is more likely to give rise to a fetus, which will eventually grow into an individual who has a definite increased risk of developing certain severe mental illnesses, particularly paranoid schizophrenia, chronic paranoid schizophrenia. How this operates is not yet elucidated, but we must be aware of these facts. There is an interesting phenomenon of fetal alcohol syndrome. When the mother ingests a lot of alcohol during her pregnancy, it doesn't commonly arise during pregnancy. I mean, it doesn't start during pregnancy. It has been going on for some time, but she continues to ingest alcohol. And that fetal alcohol syndrome has been related to a lot of neurodiversity in the fetuses. But let's take heart. Even people like Bernie Sanders and Reese Witherspoon are well-known people in the field of politics and the arts. They have done very well in spite of being born of mothers who had a problem with alcohol. They were born with fetal alcohol syndrome. The fetal alcohol syndrome has its stigmata in the form of the brain structure and the facial appearance in many instances. But does it increase the risk of schizophrenia? So far, the result has been just beginning. It seems to suggest that fetal alcohol syndrome can indeed predispose people to schizophrenia. The final biological factor I'd like to mention over here is substance use. Heavy or very early beginning of drug use, especially cannabis, certain brain stimulants that are used mainly for a condition called ADHD. The methylamphetamine is the commonly available one in India. Then there are drugs that are taken for their hallucinogenic properties such as LSD. All these can trigger or worsen severe mental illness. And this aggravation occurs particularly if there is a genetic predisposition to the condition. Next. Now, genetic factors are tremendously important. Let us never neglect our attention to them. Sorry. The strong hereditary component, how do we know? We know if in the general population, the risk of severe mental illness is about 1%, let us say, especially with regard to schizophrenia. If we look at first-degree relatives, those are the closest blood relatives of this individual, a parent and a sibling would, of course, an identical twin would be the ideal person who has the same genetic constitution as our index patient. Then if we look at other close relatives, the parent or the sibling, there's a 10% risk in first-degree relatives. If we look at identical twins, which the thing that I mentioned a little while ago, the risk goes up to 40 to 50%. But then again, it's not 100%, telling us, therefore, that the risk is not entirely on account of genetic constitution. Very interestingly, in the 50s, starting in the 40s, it was postulated. In the 50s, the research actually started. They looked at children who had been adopted. Now, if you have a commonality with the adoptee parent and the child, then that trait is entirely environmentally determined, as we know. That environment includes nutrition, of course, because parent and child are likely to have the same nutrition, the same intake of food. But if we have the opportunity to look at adopted children who have the illness and manage to trace their biological parents and find a commonality, then we will know that this is actually inherited from the biological parent, nothing to do with the environment. Now, such adoption studies could be done because in the Scandinavian countries, particularly in Sweden and Norway, they maintain registers of adoptees very, very carefully, and you could trace the biological relative. There were ethical issues, of course, in going back to the biological parents, but what they found was a child raised away from the biological parent, if the biological parent was diseased, that child was at a much greater risk for schizophrenia than compared to the adoptive parents. Again, giving support to the notion that genetic factors do operate. However, as we notice with the identical twins, genetics do not guarantee the illness will develop. Many with a genetic predisposition never develop the illness. That is the riddle that we have. And we also have the newer science of epigenetics. When you go beyond the genes alone and look at other factors that can affect the biology of the individual, again emphasizing that biology is very, very important. Next slide, please. Any takers for who these individuals are?
Quadruplets.
Yes, they're quadruplets, but
So the context would be some having developed severe mental illnesses and some didn't. Parental factor.
You're not correct, but you're as they would say in the hot and cold game, you're hot. Okay. So these were the so-called Ghanaian quadruplets born in the USA, and these 4 girls were born into a family where other mitigating factors interfered with them. But the interesting thing is they were all born in 1930. Of course, quadruplets have to be born in the same year. And all of them eventually developed schizophrenia. Seymour Ketty, who was one of the leading psychopharmacologists and psychiatrists in the USA at the National Institute of Mental Health, became aware of this and brought these people closer home for actual research. And a lot of research was done there. Some of it seems to be controversial. To my mind, the controversy is not so great, but there was a psychologist called Philip Rosenthal who studied them in much greater detail. The onset of the illness all occurred in a span of about 19 months, from the first to the last developing schizophrenia. All of them developed schizophrenia. All of them went on to have different types of achievements in life, and that is very, very interesting. While one could hold on to a job and earn for herself, she took the major interest in seeing that the others also had a better quality of life. Some died a little earlier, some died much later, but they were all born in 1930 and were subject to study in the 1950s in the NIMH in the USA. There have been other criticisms about this kind of study because what we are aware of now is that the parents were not uniformly caring towards these individuals. Some of them were subject to gross abuse because the father was a very strict Christian and he believed that masturbation was a grave sin. When he found that 2 of the girls were indulging in masturbation at a very young age, just knowing that genital stimulation gives a sense of fun and fulfillment to some extent, he actually interfered with their sexual functioning through putting them through surgical procedures that prevented them from having any joy in masturbation. Also, he was a very harsh father. The mother, on the whole, was a very caring mother, and she did not interfere with their upbringing or make any engage in any sign of partiality towards any one of them. They had different academic achievements, as I've mentioned. Some of them went on to have children, but all of them developed schizophrenia. Lending to us the proof that genes play a huge role in the genesis of severe mental illness. Next slide is a partial repeat of the first slide, but if you look at the little girls, the same girls many, many years earlier, you see they look perfectly normal children. And this is the fact with severe mental illness, that their physical appearance may not give you any clue at all. But there are unfortunate adversities that attend upon severe mental illness that we sometimes know from a person's appearance that, hey, this person is not all right. Does he have some kind of a mental aberration? Here you see these sweet little 4 girls, and then they've grown up. 2 of them, to my mind, look quite normal. 2 of them, because of their dental appearance and their overall physiognomy, suggest that there's something going wrong somewhere. Next slide, please. Just in a lighter moment, this is something American wit had this to say: insanity is hereditary, you get it from your kids. Alluding, of course, to the burden that, sorry, I have a bad throat. You must excuse me, Vijay, and all of you. The burden that parenthood brings on people drives some people to be crazy, but this is only in a lighter vein. Next. Let's move on to psychological factors that operate in the genesis of severe mental illness. Trauma, and this is a word much bandied about these days. You even have psychotherapists who specialize in trauma-based therapy, which I find a little laughable, but we'll leave that alone for the time being. Childhood abuse, we'll have a little more to say about that, neglect, or witnessing violence can increase the risk of developing severe mental illness. Now, when a child is exposed to violence within the family, domestic abuse, the parents are fighting, the father sometimes beats up the mother, very rarely the other way around also. This does seem to interfere with the sensitivity of the brain, not only of the mind, but also actually of the mind substrate, the brain. And this seems to increase the risk of severe mental illness developing later. Stress and coping can be compromised quite a lot, especially if you have a family where parents display behavior that is inappropriate, getting angry too easily, being too passive. Does this predispose people to developing chronic severe mental illness? Possibly, but we don't have robust evidence for that. Inability to cope with stress or trauma may contribute to the onset of the illness, and here modeling is very important. Modeling in the form of looking up to your parent, and most children tend to imitate parental behavior to a great extent. This seems to be something that is just a hint just now that it contributes to SMI. Cognitive vulnerabilities, certain thinking styles, distorted beliefs, excessive emphasis on certain beliefs. They could be religious, they could be societal. A tendency to be very suspicious of people around you. Having people around you who have a poor emotional regulation, and this gets imitated. These are risk factors, especially in schizophrenia and in severe depression, but they are not the major factor. Next. When we look at child abuse takes various shapes. There is emotional abuse, and this is the most devastating of the lot. And emotional abuse almost invariably attends on all the other forms of abuse. The range of child abuse includes physical abuse. In my mother tongue, the dictum used to be chhadi vaze chham chham vidya yehi gham gham. That means, or spare the rod and spoil the child in English. That harsh disciplining with a lot of physical methods and no correction afterwards. That was what was most devastating. Sexual abuse, to which we have been alerted much more in recent times, chronic sexual abuse particularly, and child neglect. Emotional neglect as well as physical neglect, especially in impoverished societies or in very busy parents who have no time for their children. These are the two ends of the economic spectrum, socioeconomic spectrum, where neglect occurs. All these are forms of abuse, and all these, if they occur, are more likely to increase the risk of severe mental illness. Also, abuse occurring is a one-off. A father getting angry just because of a very devastating circumstance and thrashing the child once is unlikely to cause a devastating result, provided there is some compensation afterwards. Chronicity of abuse and no effort at correcting the abuse are the important factors that make childhood abuse much more likely to be devastating in terms of generating severe mental illness in the long run. Next. So, is it time to abandon psychological theories of the origins of severe mental illness? We had 2 important studies that were going on in the middle part of the last century. I already mentioned the schizoprenogenic mother Frida from Reichmann, a very devoted psychoanalyst, a very caring psychiatrist, came up with this idea that a cold mother is likely to beget a child who will have schizophrenia. A cold mother, indifferent, with a style of disciplining which was rather harsh, though it might not be physically actually damaging directly. But the damage occurs subtly at the level of the brain. This was called the schizoprenogenic mother, or the refrigerator mother, as she was called, because of her coldness. Now, we know that there could be explanations for this rather than linking it directly to the causation of the illness. Another famous psychiatrist, a professor at Yale, clung on to the idea that parental styles were the ones that were responsible, or rather aberrant parenting styles were the cause of schizophrenia arising in individuals, particularly in catatonic schizophrenia and paranoid schizophrenia. Now, marital dysfunctions, there's a schism. That means there is a huge difference between the two parents, and that causes a lot of hostility. There is a skew. That means one parent takes over the parenting role altogether, and the other parent's influences are totally minimized or curtailed. Or there's a pseudo-mutual masking. At different times, different parents take over certain roles. All these were supposed to predispose an individual to schizophrenia. Now, what do we know? Now, Theodore Litz, whom I mentioned, went on in the face of biological evidence of biological causation of schizophrenia to insist that marital dysfunctions were responsible. And he had come up with very interesting literature, which we don't have the time to go into, but he stuck on to this. Now, these functions that Litz described, probably these are epiphenomena rather than the causative factors. In other words, they have a milder degree of aberration in them, which is why they engage in this kind of cold behavior or hostile behavior within a dyad of parents, and that may be generating the schizophrenia. So at best, they can be considered aggravating factors in the genesis of severe mental illness, particularly schizophrenia. Next. Next slide, please. Now we go on to other factors, environmental and social factors. Early life adversity, including poverty, unstable family life, families that had to move from place to place to place. And this happened a lot during the Great Depression in the USA in the middle part of the first half of the last century. It was felt that was contributing to schizophrenia. Certainly there is non-robust evidence to suggest that people who had frequent need to move the family on account of economic circumstances more than anything else, and those economic circumstances also caused families to break down, families to split up. Exposure to community violence was also considered a factor. Now, these are contributory factors, but unlikely to be the main causative factors in the genesis of mental illness. The great Dr. Vivek Murthy, we're proud of him because he is of Indian origin. In fact, one more feather in our cap, because he's from Karnataka. Dr. Vivek Murthy was in India recently. He was the Surgeon General of the US under two presidents of the US. The epidemic of loneliness. I was very proud of thinking that I coined this term, the epidemic of loneliness. Very sadly, I had to give the credit to Vivek Murthy, who actually said it before me, unknown to me. The amount of loneliness that attends on people's lives seems to be an aggravating factor for the genesis of severe mental illness. Major life stresses, and especially if there's an accumulation of number of stresses coming in one individual's life within a short span of, say, about 1 or 2 years, like the death of a loved one, particularly the loss of a parent at a vulnerable age of adolescence, loss of a job, relationship breakdowns, all these are contributory factors, but they're not the main causes of the breakdown in causing severe mental illness. Cultural and systemic factors have also been implicated. Discrimination, lack of access to healthcare, social stigma, all these can worsen or prolong the illness. Are we sure that they bring about the illness? Not at all. Finally, very interestingly, recently, there has been some interesting literature suggesting that climate change in people who are living in areas where there is frequent climate change may be prone to various health hazards, including mental illness. Next slide, please.
Yeah.
Anomie. This was a phenomenon recognized by a French sociologist who mentioned that he mentioned this in the context mainly of suicide, but it's also very important in the context of chronic dysfunction that occurs. Anomie is a phenomenon where a society exists in the background of constantly changing norms, no stability in the society, and anomie begets a lot of misery. And when that misery becomes insurmountable, it contributes also to increased occurrence of suicides. We know this about suicide, but does it also contribute to severe mental illness? Probably as a forerunner of the suicides, in a substantial fraction of these individuals, anomie precedes the occurrence of severe mental illness, precedes the occurrence of suicide. There's a speculation that warrants our attention. Next. Broadly, this term has come into currency a lot. Adverse childhood experience, which includes physical abuse and neglect, household member who has suffered from mental health issues, sexual abuse, and sexual abuse, especially starting at a very early age and going on chronically, contributes to adverse childhood experience. Loss of a parent due to death, divorce, or abandonment. All child abuse I have mentioned, and this bears repetition. Emotional abuse necessarily is an accompaniment of different forms of abuse. Emotional neglect, household member addicted to illegal or illicit, I should say, drugs or alcohol, household member who was incarcerated, not a very common phenomenon in our research from India, witnessing domestic violence, especially domestic violence where the mother is berated or even violently physically abused. All these are adverse childhood experiences, and the cumulative effect of adverse childhood experiences does seem to contribute to a later mental breakdown. Next slide, please. We've looked at the causes now. Let's move on to the shoots. Now, severe mental illness is defined as a condition characterized by significant impairment, dysfunction, disability, and disadvantage. These four terms are slightly different from each other. There's a huge overlap. There's a continuum, in other words, which may include symptoms such as hallucinations, delusions. I will not carry coals to Newcastle. I think our audience is educated enough to know what these are. Lack of vocational and social skills, unemployment, and experiences of poverty, discrimination, and stigmatization. All are the offshoots of the genesis of, after the genesis of mental illness, particularly severe mental illness. Next. Now, what are the psychosocial adversities that ensue upon severe mental illness attending on an individual? This was a slide I prepared long ago for another presentation, but today I'm very happy to include the word can over there. These are exactly what we hope to prevent. So what psychosocial adversities can ensue upon severe mental illness attending on an individual? Of course, there are disruptions in family life. It's difficult for people in the family to come to grips with the fact this person suddenly is hearing voices or has a strong notion that the neighbors are poisoning him, or within the family, somebody is doing coercive and maladaptive acts that can make the person feel persecuted. Individuals who have severe mental illness, their academic career gets held up and sometimes even failures ensue. And this brings down the self-esteem of the individual, contributing to an emotional upset, which aggravates the mental illness. Increased risk of finding, man is an animal who tries to correct himself all the time by taking chemicals that will set things right. That's how alcohol really entered the scene. So increased risk of substance abuse and dependence on these substances is also there. Social isolation, feeling derelicted, having no connections at all, happens when the illness has gone on for some time. The family gives up. In not a small number of instances, the family abandons the individual. Even when the family has not actually indulged in abandonment, there can be a sense of dereliction. Poverty ensues for the individual, especially in adulthood, when they can't fend for themselves. Physical illnesses tend to occur much more commonly in these individuals. And on the other side, you'll see early death. Physical illness tends to be neglected, and that may contribute a lot to early death in a substantial number of people who have severe mental illness. We've already mentioned the stigma that attends on severe mental, because their behavior, their appearance, their mannerisms all become the subject of ridicule or isolation, and that is a stigmatization. People with severe mental illness very commonly have sexual needs that are just like other individuals. And because of their aberrant appearance and behavior, the stigma leads to sexual frustration because people don't want to be associated with them. I would hark your mind to an excellent movie about mental illness, if Vijay will permit me. One Flew Over the Cuckoo's Nest is an iconic film where we look at mental illness in a ward. I don't know if it's a mental hospital or a ward in a general hospital where severe mental illness is being dealt with. And there is this young man who has never experienced sex, though he's been attracted to it. And there is one event that occurs where he has exposure to a semi-romantic, physical, fulfilling sexual encounter. And his behavior changes so radically. He's suddenly a confident individual. The stammer that he has disappears completely because he's had this one evening of a good, fulfilling sexual life. And I notice that in a few individuals, I don't think this is substantiated by research just yet, I'm open to correction, that if you have sexual fulfillment, the chances of your disability is that the degree of your disability is greatly reduced. The degree of your confidence is greatly increased. That these are facts we should be aware of. Of course, if people have severe mental illness, then they are quite likely to engage in aberrant behavior such as domestic violence. And the domestic violence can occur both ways. The severely mentally ill person, most commonly because of paranoid delusions, engages in violence towards the spouse. And the other way, a spouse who is very frustrated because a person with severe mental illness cannot actually fulfill the role of a life partner. That spouse can engage in physical violence towards the affected individual. We know that there is an increased risk of divorce, and this does not go only with arranged marriages, though it's more common there. Also with so-called, in India, we have these two dichotomies. We have a love marriage and a hate marriage. We have an arranged marriage and a misarranged marriage. One way or the other, the risk of divorce is much greater over there. People with severe mental illness are not likely to be able to perform the functions of normal parenting, and faulty parenting results. And that might be the genesis of the schizophrenic mother. Please remember that. That individual might actually have had a minor degree of a mental aberration. There's a slight increase of risk of suicide when severe mental illness is there. This is particularly true. The risk is much more for highly educated people who had a psychotic breakdown and have not been able to get back to their earlier academic achievements. There, the risk is the highest. So males who have completed college education seem to be at the greatest risk for suicide when severe mental illness is there. We've already mentioned early death. And of course, with severe mental illness, the chances of a person being abandoned, especially after the parents have gone away, and they have not been foresightful enough to make arrangements for the individual to be looked after in a home or through other relatives who are hopefully caring. Very often there are other relatives to whom this person is handed over, and they say, we have nothing to do with it, we can't put up with this kind of behavior, and the person gets abandoned. So these are actual psychosocial adversities that ensue upon severe mental illness. Next, please. One word about marriage, and I'm very passionate about this. It is very common in our country to believe this, shadi kar do, sab kuch theek ho jayega. This is linked to the notion of there is sexual frustration. Once this person gets a life partner, things are going to be all right. Sexual fulfillment and physical and emotional fulfillment through marriage is going to make this person completely all right. A very common notion even today, though I must say, compared to the time I was doing my post-graduation now, this phenomenon has visibly reduced. Marriage is never to be considered a remedy for severe mental illness. Please remember this and convey it to anybody you have chance to deal with who has a severe mental illness. It was very nicely put by one of my students who said, instead of one life being miserable, two become miserable. So this is a tenet to be kept in mind. The other thing that happens commonly in our country, shadi kar do, sab theek ho jayega. You conceal from the other party, especially in the context of an arranged marriage, very rarely the other way around. The suppression of the truth of a severe mental illness causes devastation to the other party, and there is a lot of bitterness, legal fights, and even physical violence that are very difficult to neutralize afterwards. Next slide, please. Okay, so part of the shoots, one is the psychosocial adversities and what can be done in managing severe mental illness. Next slide, please. I tend to fall back on literature, which is my second love after medicine. So I have this passage from Shakespeare's play Macbeth, very nicely put. Canst thou not minister to a mind diseased, pluck from the memory a rooted sorrow, and with some sweet, oblivious antidote, cleanse the stuffed bosom of that perilous stuff which weighs upon the heart. Macbeth, who is now king, sees that his wife has had a sort of mental breakdown. She keeps imagining that she has bloodstains and she keeps trying to wash them off. And the physician is summoned that he's desperate for the cure for his wife. Unfortunately, it never actually occurs. That's a spoiler for those of you who don't know the story of Macbeth, but we'll move on. Medication is the mainstay of management in our present state of knowledge. Medication, medication, medication. But when we go on with medication, 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 we must remember that medication needs to be used with a clear, humane touch. Okay? This is very often forgotten, and I hang my head in shame on behalf of a minority in my profession who don't take adequate care to ensure that humane touch. Next slide, please. When we come to medication, and I gave my apology right at the beginning, I'm not going to mention specific medications at all. We are not sponsored by any pharma company today. So attention to clinical features. There are drugs that are useful for a mania. There are drugs that are useful for a depression. There are drugs that are useful for specific kinds of symptoms, which we call positive symptoms. There are drugs that are better used for negative symptoms. There's an overlap between many of them. We have to pay attention to the dosage. The dosage, generally speaking, should be gradually increased. That way we reduce the risk of adverse effects attending on the individual. And there has to be a titration that is done with the dose and the symptoms. We also have to ensure adherence to the right kind of dosage. You notice that very intelligent people also sometimes do not want to take medication. Why should I take medication as a standard? I'm not all that bad, or I'm not bad at all. This happens. If you remember that movie, A Beautiful Mind, where the wife is the mainstay of support for this individual who has paranoid schizophrenia, she notices after some time that there is no improvement, and with the help of a family friend who's also a doctor, they come to know in his drawer, all the medications have been stored and stashed away. Ensuring that regular medication is given is tremendously important. Also, the sensitive doctor should be aware of what side effects are known. Sometimes a rare side effect can occur even if the literature doesn't say so. They should be sufficiently sensitive about that. And where adverse effects have occurred, for example, with many psychiatric drugs, we know that heightened blood sugars are there. Refer to the appropriate consultant. If you can manage other psychological side effects that are there, manage it yourself is the advice to psychiatrists. Many drugs need close lab monitoring, especially the drug lithium, which is used in the treatment of bipolar disorder. It's very important to have. There's lab monitoring required for various medications. Generally speaking, checking on the liver function tests and the lipid profile are very, very important. Many drugs have cardiac side effects, so adequate monitoring of those through an ECG and, if necessary, take the advice of a physician or a cardiologist is very important for psychiatrists. Very rarely do we reach a state with severe mental illness where we can actually consider reducing the dose. The cardinal rule used to be 2 years of a symptom-free period. taper the medication over 6 months to 12 months, and then you can stop it. We now find that less than 4% of people can actually afford to stop their medication in our present state of knowledge. Next. Now, does psychotherapy have a role? In certain quarters, especially in the West, there is a belief that the entire treatment should be psychotherapeutically oriented. We no longer cling to that opinion in orthodox psychiatry. We now believe that psychotherapy does have a role, but it's a role on the back seat largely. First and most important is educating the patient and the carers of this individual, most commonly the family, that this is a biological process that reduces their feeling of guilt and the necessity to stigmatize this individual within the family. So psychoeducation is the counseling that must take place in the case of severe mental illness. The bandwagon onto which everybody jumps is cognitive behavior therapy. Now, cognitive behavior therapy is based on a belief that there are faulty belief systems, faulty ways of thinking that need correction. And if those are indeed evident, then CBT is likely to help. Individual therapy, exploring the person's psychological world. The psychoanalysts, especially those who veered away from Freud and went on to Jung, laid great emphasis, Freud also did, on dreams of the individual. Now, these need some exploration, but they're very unlikely to be able to resolve what's going on in this person's mind. Individual therapy, helping the person to have a place to ventilate, that is very, very important. In psychotherapy, the most important skill is listening, listening, listening. At the end of listening, it's not enough. It's not, an empathetic heart is not enough. There have to be solutions. Holding the hand, reassuring the person that, I know what you're going through, but this is unlikely to be based in reality sometimes, is a message that needs to be conveyed with great diplomacy. Not dismiss the individual's delusional system, for instance, but absorb it and say that we'll find different ways of dealing with it. That calls for the creativity in the psychotherapist. Also, many of these people have, am I running out of time?
Not at all. Right. Sorry, I jumped the gun. Sorry.
Social skills training, where their social skills, sometimes picked up social skills are dropped, but very often they have not picked up certain social skills. How to make conversation, how to interact socially, how to take responsibility. These are social skills training. And I indulge a lot in one particular genre, that is psychodrama. I don't do psychodrama in the Moreno model, but I do believe that role-playing helps a lot. So when you go to a party, there's going to be a problem. How do we do it? When we have a situation where you're going to be asked tough questions, how are you going to answer them? Let me play the patient. You play the father who asks awkward questions. You play the outsider who's going to subject you to an interview. This kind of rehearsal is a great strategy in mental health in general, especially in the context of severe mental illness. Rehearsal, I have been told, robs the life of spontaneity, and that has got a grain of truth, I will not deny, but spontaneity isn't everything. As my favorite author used to say, if you're going to rely only on spontaneity, never take medicine for worms. It's natural, let the worms be there. So depriving life of a little bit of spontaneity is worth the trouble, especially in the context of social skills training. Next slide, please. So summing up, the biological basis of severe mental illness is firmly established, but this does not negate the relevance and importance of psychosocial factors that contribute, such as adverse childhood experiences. The management of severe mental illness is largely, but not only, based on chemical, that is medication interference, chemical interference, that's medication, which has greatly advanced, but is far from ideal yet. Okay. Next. Psychotherapy does play a role, even if it takes, relatively speaking, a backseat in the treatment of severe mental illness. All the interventions must be aimed at enhancing the quality of life and actively reducing the risk of the well-known psychosocial adversities we mentioned in some detail that can attend on severe mental illness. Next. I'd like to conclude with this cute little poem I came across a few days ago. In fact, after I chose the topic, I crave your indulgence to listen to this. I must also confess that I have not got in touch with the author of this particular poem. Broken tree. See the stump of a tree, ravished before a terrible storm. The terrible storm in our context being the severe mental illness. Its new shoots has grown big and now bearing again the sweetest flowers and fruits. A little fanciful, but let's hope for that. And so it is. So it is in life. Terrible things do happen, causing painful memories and scarring, but never to give up. Next. Again, to end on a slightly lighter note, Carl Jung, one of my favorite people in the field of mental health, show me a sane man, says he, and I will cure him for you. The context is very different. We haven't the time to go into it, but this is something which struck me ever since I started reading Carl Jung. Next. Thank you. Thank you all of you for your patient listening. I'd be very glad to interact with you if Vijay gives us the time. Thank you also to the MHSF, to Bipolar India, and very, very particularly to my friend Vijay Nallawala.
Firstly, thank you so much for this amazing presentation. I think through this presentation, and we also thank you that you had geared it for the kind of audience you are addressing. There were no professionals coming in. I mean, that's an assumption. There might be a couple of professionals who might have joined in as well. There were a few requests to me from the social media posts that we had done. But for the large part, there are people living with severe mental disorders and their family carers, doctor. Right?
I think the sharing has gone now.
Yeah, yes,
suddenly showed up.
Thank you so much, doctor. So the presentation was so then customized to the, what are the concerns of the audience that you spoke to today, doctor. And we are really thankful for all the insights that you shared. Before we throw it open to the audience for a few questions, and I hope you'll be there with us for a little while longer.
As long as you want.
Oh, fantastic, fantastic.
I have divorced my wife for today. She's watching, I believe, somewhere.
So, now a few questions from the notes I made from your talk, and I mean, there was so much that came up to my mind, and again, the questions which would be relevant to the community, right? I mean, I'll be asking questions which are pertinent to the larger interests. So you mentioned one thing very interesting, that sometimes the times of the year when an individual is born contributes to the mental illness. Could you elaborate a little bit more on that, doctor? That's because it's very fascinating too. I've never heard of this kind of a phenomenon.
Spring, summer births are supposed to be protective towards severe mental illness. Winter births predispose to mental aberrations, mainly schizophrenia, but the evidence is not robust yet, to my mind. I've argued about this with people who have come up with the notion, and I won't dismiss their finding, but winter births are supposed to increase the risk of severe mental illness.
Thank you for elaborating on that. See, very related to the theme of your presentation, doctor, and the topic itself, we talk about the delay in diagnosis, especially in a country like India. How do you, what do you weight that factor as contribution to development of severe mental disorders? Meaning that the gap between onset of symptoms and diagnosis and treatment.
Okay, so there is a campaign, especially in Australia, about early intervention. So start treatment very, very early. The moment you see a symptom, start the treatment. And they seem to believe, I have not adequately been convinced, that early intervention makes a huge difference. But delay in intervention does make a difference. For example, if an illness has gone on for more than a year before the treatment is sought, and that is very commonly in our country and in other countries where the beliefs in traditional systems is much stronger, the actual useful medical intervention gets delayed. And there, the chances of the illness going on to a severe chronicity and severity is much, much greater. So start treatment within the first 3 months is ideal. Australians, I forget the particular psychiatrist is about my age, who introduced this 20 years ago, early intervention. Start treatment as soon as you notice a symptom. I feel antipsychotics have certain risks, and I'd avoid it. I'd wait for the illness to be more manifest, unless there is the danger of violence to
Yeah.
oneself or to the society.
Sure.
Drop in academic performance should not be taken straight away as a sign of severe mental illness, which happens very commonly as the only symptom that has occurred in an individual.
Right.
Wait, analyze a little more. That is my approach.
Sure. Thank you for elaborating on that query. Also, one very significant issue, there are a lot of family caregivers in this meeting, and a question that might vex their minds on a number of occasions. You talked about the issue of stoppage of medicines. You referred to the story of the beautiful mind, the iconic movie. Now here, I'm putting you on tricky ground here, doctor. Where it comes to the Mental Health Care Act, the right to informed consent, agency, autonomy of the person, and then the role of families. What are your personal views on this? How do we navigate this? You would agree that this is quicksand, and families face this very often. I myself am a family caregiver, by the way. So this it's a moral, ethical dilemma, and also then the legal aspects.
First, a small note of admiration, because to admit that I am a carer takes some courage, and I'm glad you have it. Of course, you're a seasoned player in the field, so I'm not totally surprised, but I think we should be open about these things much more commonly than is obtaining at present. Now, I don't know why the onus should be on the family. Two brothers, one has a mental breakdown, the other is leading a prosperous life. He doesn't want to look after. We have no right to impose it on him, as far as I can see. I must also confess that my familiarity with forensic psychiatry is minimal. So what ensues upon what constraints arise on account of the Mental Health Care Act, I would be a poor, we should get somebody like Suresh Badamat or Mrugesh Vaishnav to talk to us about that particular aspect, because they're well up on that. The obligation of the family to look after is incorrect. Okay. Most families are caring to varying degrees, and they do want to take care of the individual because of affection and other considerations also. Yeah. It can be as mundane as property.
Correct.
But they want to take care of the individual. That's something we should capitalize on, psychoeducate them about this being a biological process that needs biological correction above all, but not only biological. I'll go on emphasizing biological and not only biological. So yeah. that is my approach. The tricky question is when somebody has no insight into his illness, yes, what can we do? And there are provisions in the Mental Health Care Act, I understand, but whereby we can, I rely on two stalwarts in my city. One is Suresh Badamat, whom I mentioned, and Dr. Mahesh Gowda. These are the two individuals who help me with involuntary hospitalization of patients who have a lack of insight. So there are such individuals in every city, fortunately, who can help us out with being on the right side of the law. Sure. But I know that somebody is in danger of impairing, I'll say her, because very recently I had to deal with this, and Mahesh was a great help. Taking a person away from the normal surroundings to a hospital, hospitalizing, seeing that things are all right. The other person who has helped me greatly with involuntary hospitalization is a professor at NIMHANS, Dr. Venkat Subramaniam, who is an expert in schizophrenia. He has been a great help to many of my patients. So taking this person to hospital becomes a responsibility that the family usually has to sign papers to say that we are doing this. And the magistrates nowadays are well trained to recognize where humane interference is called for.
Sure. Thank you for that clarification. So in fact, we have conducted one of the first workshops on the Mental Health Care Act addressed by Dr. Soumitra Pathare himself. And you know the role he has played in that, doctor, right? So understand the nuances, right? So I know a lot of those technical aspects, but what happens is, doctor, then, sorry, so you're saying something, doctor?
No, I said Soumitra, unfortunately.
Okay.
Because this was I mean, the path to hell, they say, is paved with good intentions. Soumitra's intentions were not suspect at all. But I mean, the Mental Health Care Act looks at our profession with great suspicion.
Correct.
I dislike that. I don't want to get into a debate about this. I've had enough
Sure,
debates
sure.
with Soumitra, whose clinical skills I still admire.
Yeah.
But
No,
this was
definitely.
to my mind, usually a copy and paste job. And our culture is very different from where it was copied and pasted.
Sure. Yes, very much so. So, in the Indian context, families do play a very integral role in the caregiving aspect. And sometimes it might not be from the, sort of suspicious angles or angles looked down upon, as such as you mentioned, give a hint to, such as property or other such aspects, but out of genuine love and care. And then, okay, so you talked about one aspect of the act. So, yes, that admission to hospital is possible when the person loses capacity to take decisions on
Right.
his or her own. Yeah. So, that is where the family carer can step in. Yes. But when we come to the preventive part of it, when the person is not taking the medication and we can see the thing situation blowing out of hand, then what are your views on that? So, because surreptitiously administering medicines is also ethically an issue as well as now debarred by the Act, Doctor.
For me, the ethical issue is to act in the best interest of the patient. So while surreptitious medication has been frowned upon, and have
Yes.
lengthy discussions with this, particularly with North Indian psychiatrists in North India, Anirudh Kala and Alok Sareen, who are very committedly against it. I am not against it.
Right.
But we need to have other provisos whereby it can be legitimized. That's my take. I've
Right.
had lengthy discussions, I won't say debates, with Nirmala Srinivasan, who's a very leading person in the dealing with mental illness through Face Me. And she had to apologize to her relative patient, about having used surreptitious medicine while it was doing a whole lot of good. Yes, the law, and we imitate the West in the law far too often, prohibits it. And so I also no longer do it, much as I'm in favor of it.
Sure. Thank you also for sharing your stand on this. And, because it's very difficult to share it on public domain, because this is, again, a little controversial. But I
There was
concur with the.
somebody's had a post on social media,
Yeah.
psychiatrist who moved from India to the US, a young psychiatrist. It was called A Tale of Two Cities. That is a very telling small
Amazing.
document about how much he could help people in Bombay and how much he could not help people in New York.
Right. So, interesting take on that as well, Doctor. And I agree. I mean, when you go too much on the grounds of agency and autonomy, disregarding the need for care for their individual's care, I think that yes, that is something that should break our conscience, right? In the right ways. Yeah. What you said about marriage is also so relevant, Doctor. A lot of the community members have chosen not to be married, knowing about the repercussions, and that is also an unfortunate reflection on society, that acceptance of severe mental disorders, the stigma prevailing, the stereotypes around it, uh, debar a person from participating fully in society, right? I mean,
Very true.
and that is the human need is, a person is deprived of a basic human need, social belonging, family belonging. Okay? And meanwhile, I must thank Dr. Ajit Bhide on behalf of all the participants and those people who will be watching this recording time and again to gain insights, inputs, and knowledge from it, from the YouTube channel on which we'll be posting it. It was a completely mind-blowing session, Doctor, right? And also it came from a very humane perspective, not very much, the terms used from the clinical jargon were limited, and only where they were relevant and you had to bring them in. I think respect from all of us for taking that kind of an approach in your presentation as well as in your responses to all these queries. And some of the queries might seem trivial to you or insignificant, but I guess some of them bother the people a lot, right? Yeah.
Some of them were not insignificant, but they were irrelevant to our topic of
to the
the roots and
topic,
shoots of severe
to the
mental illness.
topic.
All of them were very interesting.
Also, just before we close, doctor, one question we could have bring in is comorbid mental health conditions. You threw light on ADHD. My own ADHD was diagnosed just 2 years back, doctor, and accidentally. Okay, OCD also have a comorbidity. So many times the comorbid conditions are not identified due to the patient's incomplete narration and same from the coming in from the family. Is that a factor which would lead to the psychiatrist or the
Definitely.
psychologist to say?
Comorbidities are missed for two reasons. One, they, they forget to mention it,
Yes,
which is, I think, the most common factor. The second is embarrassment.
right.
Most people with OCD are very embarrassed about the peculiarity of their symptoms, and that
Yes.
keeps them from discussing it. I'm preoccupied with soiling the deities in my puja room. That is so embarrassing to discuss. But a
Yeah.
doctor can't be asking the whole gamut of OCD symptoms that could be there. So we can only ask, are there any thoughts that trouble you a lot because they come again and again and you can't ward them off? That's the best the doctor can do. Comorbidities with OCD and severe mental illness are well known. Comorbidities with substance abuse and severe mental illness are well known. Comorbidities with psychobiological dysfunctions, constipation and sleep disturbances are the most common that need adequate addressing.
Amazing. Even that input is great.
My email address is rajitbhide@gmail.com. Feel free to communicate with me. I'm a reasonably good correspondent. Sometimes I fail, in which case you repeat your.
Fantastic, doctor. I think let's adopt that route. Doctor has been generous, and even more so, he's willing to come in for to address specific sessions on other themes that were, requested, such as personality disorders, and maybe the other things we can brainstorm on, which will be very relevant to our community, right? So, if he could please excuse doctor from any other questions. I think the broad spectrum of questions related to the theme today were addressed in quite in depth. That's my personal take on this. I think majority here would agree with this overview of the session today. And again, deep gratitude from all of us present here today at MHS, from the MHSF community, some from beyond it, doctor. Really, really insightful session from which, and you shared all your in-depth experience and insights with a lot of humility, where you admitted your lack of expertise in certain areas of psychiatry, medicine. I think we must appreciate those aspects of your facilitation today as well.
May I say I was delighted to be here, and I'm amazed at the kind of interaction we've had, which has been very educative for me also. And I'll look deeper into certain aspects that I could not address.